till now we had all three speakers were softer. So now I would like to invite Dr. Richa,
Yeah.
who is an aggressive speaker and my very good friend. The best.
Thank you everyone for staying back till now, especially people who've woken up at 4 and slept at 2 a.m. and I really appreciate it. So I'm going to talk about MR, whether it is the way forward for hemodynamic significance. And I would say, I think all the previous speakers have made my talk easier. So I'm going to talk about what is stress CMR and what is the evidence about it, where does it stand, how does it compare to other modalities, and what are the advantages. So just a little bit, so in MRI, we do pharmacological stress MRI, or we obviously cannot do physiological stress as of today. And these are adenosine, regadenosin are the two vasodilators we can use. Dopamine stress also can be done. We commonly use adenosine stress. So what the principle behind it is, if a coronary artery is patent, it supplies blood to the myocardium and the myocardium perfuses uniformly. However, when you have a significant plaque, the flow to that region reduces. So normally, physiologically, what happens is, so adenosine, when we give it, simulates physiologic stress, so it causes vasodilatation. And even after that, if you see a defect, that means that narrowing is significant enough to not let enough blood, which contains gadolinium, to go. So while rest of the myocardium perfuses and looks gray, the area which is supplied by the abnormal coronary does not perfuse, and it is seen as a perfusion defect. So usually these are its common indications, especially in intermediate or moderate coronary artery disease with atypical symptoms. We do it quite often in dilated cardiomyopathy of an unknown cause, where it's like a one-stop and, tell me whether it's ischemic or non-ischemic and if there's any other etiology. So in those cases, it helps a lot. So this is an example of the stress MR, just to show you how it looks and the spatial resolution. So this is the basal, mid, and apical slices. And as you can see, the first pass perfusion, you can make out the black defect and the normal. So to still the image, so this is the first pass perfusion image where you can see this is the perfusion defect, very clearly seen against the myocardium, which doesn't have a perfusion defect and which is grayish, so which is perfusing with gadolinium. So usually we need to compare it, so we can compare it with a rest MR, or nowadays we do not do rest MR, we just compare it with LGE. What we are looking for is if there are any infarcts, because that if it's infarct in the corresponding area, then this defect would be due to a fixed defect rather than a stress defect. So as you can see, there's no infarct. However, there's a lot of ischemia in this patient. So this patient had significant ischemic burden. So coming to the evidence, this functional imaging for myocardial ischemia by the European Society guidelines of 2019 for chronic coronary syndromes is a class 1 indication. By the 2014 ESC and cardiothoracic surgery guidelines for whether to revascularize or not, any functional test, including stress MR, is a class 1 indication for intermediate coronary artery disease. However, none of these tests are indications in low or high probability of coronary artery disease. So as I said, intermediate coronary artery disease is one of the indications. Now to talk about its value of stress MR in prognosis, there are these meta-analysis which talks about 14 studies with more than 12,000 patients, and they said that negative stress CMR is associated with a 1% event rate, which is equivalent to the normal population. So it has a very high negative predictive value. So if your stress MR is negative, it is unlikely that you will have an event or significant coronary artery disease. And this is another meta-analysis which again said the same thing about prognostic value of stress CMR. A meta-analysis of 19 studies, again less than 1% rate for a negative stress CMR, which is associated with a very low risk of cardiovascular death and MI. So it not only diagnoses whether the coronary artery disease is significant, but it also prognosticates the risk and risk stratifies if it's a negative MR. This was a SPINS registry done in the US, again similar, which talk about the prognostic utility of stress MR. And they said that patients without ischemia or infarction had a 99.3% event-free rate over a period of 5.5 years. As we can see, these are European Society, American College, and American Heart Association recommendations of use of MR in coronary artery disease, and we can see it's a class 1 or 2A recommendation in almost all the indications. Coming to comparing it with other modalities, MR was a modality which developed later compared to SPECT. So earlier SPECT was done and considered the gold standard. Now MR, a lot of studies, this is the MR Impact 2 study where it shows that MR is more specific in each and every case, whether it's entire study, multi-vessel, male or female. Similarly, this is the CMARC study also showing the same thing. Blue line is a cardiac MR, red line is SPECT, and it showed that MR had better sensitivity compared to SPECT in all these categories of single or multi-vessel disease. Comparing stress MR to FFR, invasive FFR is what I'm talking about in this study. And invasive FFR is considered the gold standard in invasive physiological tests for significant coronary artery disease. And this study said that among patients with stable angina, MR was associated with a lower incidence of revascularization than FFR, and it was non-inferior to FFR, especially when they compared it to outcomes. This is another study comparing MR to FFR. Again, this is a review and meta-analysis, and it again said that MR is comparable to FFR, especially if the resolution is more at 3 Tesla and FFR cutoff of 0.8. An increase in coronary artery disease further improved the specificity of MRI. So we had this prior talk on CT-FFR, which is actually part of NICE guidelines. And this is a study which showed that, which compared FFR and CMR, and it showed that they yielded similar diagnostic accuracy. So sensitivity was higher for FFR, but specificity was higher for CMR. But this other study, where they compared CT-FFR to MR, but they used MR as the reference standard. So it was essentially that they were comparing CT-FFR to a reference of MR. And it showed that CT-FFR was good enough. I cannot not mention Dr. Tarun Mittal's study, which we've been talking about, I think, since the last 2 days. And I'll just talk about its conclusion. And it said that the results of real-world audits suggest that CT-FFR in patients with stable chest pain may not be as accurate or as cost-effective when compared to alternative stress imaging strategies. So this kind of turned the CT-FFR around its head, and now it's like a debate, like, is it still valid or not? So I would come back to some of the guidelines. So this is the 2021 IACI guidelines. However, this is the SCMR perspective on those guidelines and what they have to comment on it. So according to that, stress MR or any other stress functional study is a class 1 indication, means it's a strong indication for patients with intermediate risk and no known coronary artery disease. And in patients with stable chest pain, again, it's a class 1 indication for patients with intermediate high risk with stable chest pain and those with obstructive coronary artery disease with stable chest pain. So they just kind of highlighted what are its class 1 indications, and the SCMR had some disagreements had disagreement with some aspect of the ACC AHA guidelines, and one of their disagreements was that the recommendations of FFR-CT in the guidelines are premature, and the reasoning they gave was quite long actually. And to summarize it, it said that the diagnosis as well as prognosis by CT-FFR is not as robust as any of the stress imaging modalities, whether it is stress CMR, SPECT, PET, or stress echo. And they also added that CT-FFR has limited diagnostic accuracy in detecting hemodynamically significant coronary artery disease in the intermediate range of coronary stenosis. And this is usually one of the major indications why a functional testing is done. Another, they had, they disagreed that they felt that it was not practical enough in regards to cost, and also, like Bhavna mentioned, it has limited use. CT-FFR has limited use in a lot of conditions like coronaries with extensive calcification, prior stent, prior graft, valvular heart diseases, and so forth. They further commented that in this, they have grouped the ischemia imaging modality as a group and compared it to anatomical as CT, and they felt that it should not be considered as a group. And the PROMISE trial evaluated the utility of anatomical testing in comparison to functional testing. So, and it concluded that there were no differences in adverse clinical outcomes, but anatomical approach led to downstream utilization and did not allow for further investigation of using both invasive cath and coronary revascularization. So this was the conclusion. The take-home messages by SCMR perspective for evaluation diagnosis of chest pain, and it said that high sensitivity and high specificity is seen in CMR and PET, and PET has the advantage as in it has no radiation, and stress CMR has class 1 indication in patients with stable chest pain with or without known coronary artery disease. Another thing while comparing to CT-FFR, which we cannot forget, especially sitting in India, is the cost. Like, it's almost 5 times the cost, and I don't think any of our patients, we would hesitate to send for a CT-FFR. Our clinicians would rather just do, revascularization rather than spend on this. And another is what Aparna ma'am has already spoken about, advantages of, other advantages of cardiac MR, where we are not just looking at ischemia and stopping, we are looking at the heart, or even I would say the chest cavity as a whole, and so any other abnormalities are very well picked up on CMR, as you can see in these cases like biventricular dysfunction with valvular diseases and so forth. So is stress CMR the way forward? And I think I would not hesitate to say that yes, it is. It has really good resolution, doesn't have radiation, is cost effective comparatively. And not only that, it's a one-stop test. Not only does it evaluate for ischemia, but we can also talk about viability, give functional assessment, and detect any other abnormalities like valvular heart disease, or if there's any cardiomyopathy. Thank you.
Thank you, ma'am. That was a wonderful presentation.
Thank you, sir.
Any questions from audience?
I think everyone wants to go.
So, like in Narayana, if cardiologist refers to stress MR, like what is the percentage which they refer to nuclear medicine and refer to stress MR? At present, how many cases you are doing, madam, per day?
25.
Okay.
Not all stress, I'm just talking about the overall cardiac MR, but
Stress.
a stress would be 60% of our work, 60 to 70.
Okay. So how cardiologist decide to send to either nuclear stress or MR?
So I think all DCMs of unknown cause come for MR, for sure. And if they want to do a physiologic stress rather than a pharmacological, then they would definitely send for nuclear. Otherwise, if they're not sure what's happening with the patient, you know, some strain values are weird and that's the only indication, or just some atypical chest pain and there are some other things going on in mind, or some valvular diseases on echo, then the patient comes to MR.
Okay. So I think Dr. Sunil is my senior.
Yeah.
So he is doing around 20 to 30 cases
Correct,
per
yes.
day stress.
Yeah.
You are having dedicated cardiac spec there, na?
Yes.
Yeah. Okay.
Thank
That was excellent, Richa. And you know, in addition to your excellent list at the end summarizing the advantages of stress CMR, now there are pixel-wise quantitative perfusion maps
Right.
that can look for myocardial blood flow at rest and stress, and we can even see evidence of microvascular angina in great spatial resolution. You typically will see like a subendocardial ring of hypoperfusion compared to the subepicardial area. So you can not only look at obstructive coronary artery disease, but also microvascular and dysfunction as a cause of chest pain. So it is a good one-stop test.
So I just wanted to ask you, do you regularly use quantitative
Yes, we do. Yeah,
Okay.
we actually use that as a default for our stress perfusion, because even the raw images, excluding the color maps, even just the raw perfusion images are better quality than the previous sequence we had. So even if you just look at the grayscale sequence for visual assessment, like that is better than the previous ones we had.
And what's the software for the quantitative assessment?
You have to request it from Siemens, from
Okay.
Peter Kellman, from NIH. It's still a WIP, a work in progress package,
Okay.
but it's possible to request it through Siemens.
Okay. So you're not talking about just quantitative assessment of these EPI images, you're talking about a separate sequence itself with the quantitative.
Yeah. I've actually shown it in Mumbai,
Yeah,
in Jupiter
yeah.
Hospital. I don't know, I didn't show it because that wasn't my talk, but they are beautiful, perfusion, color maps that you can see where the ischemia is, and in microvascular dysfunction, you just see this purple ring of subendocardial hypoperfusion compared to a yellow ring outside where there's increased perfusion to tell you that, okay, the patient did respond to the vasodilatory stress, but there's induced role hypoperfusion in a circumferential manner, and these people don't have obstructive coronary disease, and yet they have typical angina, so that would quite support the diagnosis of microvascular angina.
Thank you.
Yeah, thank you. So my experience with the myocardial blood flow quantification is these maps. They are these maps that they are really good, and they can allow you to visualize this, these cases of microvascular angina, and we get requests from referrers saying, look, my patient has typical angina, it responds to nitroglycerin. They don't have obstructive coronary disease either on coronary CT or on invasive angiogram. Can you see whether this is microvascular angina? And we can do that and say, yep, they have a, either very diminished stress perfusion response to myocardial blood flow, and we have to obviously ensure that we actually stress them adequately, because otherwise it might just be like a false positive. But the actual maps will allow you to see that pattern, that circumferential ring of subendocardial hypoperfusion or decreased myocardial blood flow during stress, and yet at the same time the outer ring, the epicardial ring, has high myocardial blood flow, so the patient did respond to the stress, but the endocardium is just not responding, so it's quite convincing when you see that pattern. Right. Yeah. So just for the rest of the audience, the question was for people without the software, what about coronary sinus? Well, I haven't done it, so I don't have many personal experience with it. But I think some people have done that in the past. Otherwise, I think there are complex ways to do the Fermi deconvolution to analyze these perfusion images that you have, but that is so time consuming that I can't see people doing it regularly for clinical workflow. But I think SCMR is trying to get the vendors to sort of get this into the clinical arena so people can get access to these perfusion maps, because they are really useful.
Thank you, Richa, for the excellent talk. I request Dr. Hemant to felicitate our chairperson, Dr. Gunasilan. Thank you, sir, for chairing the session and giving your inputs.